Good morning, everyone. My name is Trudy Loper. I am the Senior Director of Screening here at the Colorectal Cancer Alliance, and thank you for joining us. On behalf of the Alliance and today's Facebook Live participants, we appreciate you being here. Today's live stream focuses on the new colorectal cancer screening guidelines that were released by the United States Preventive Services Task Force on May 18th. If you haven't heard, the guidelines are a huge win for the colorectal cancer community and our mission to save lives here at the Alliance. The new guidelines state that all people at average risk for colorectal cancer should begin screening at age 45. This update opens the door to preventive screening to almost 20 million additional people, many at no cost. We estimate that it will save approximately 48,000 lives just for those in the 45 to 49 age range to which the guidelines now apply. But there's a catch. This change will take some time to become reality. My colleague, Allie Miller, Senior Director of Community Engagement, is here to go over those concerns and outline what you can do to help ensure that colorectal cancer screening is available to everyone at age 45 as soon as possible. The door is unlocked. Now we just need to kick it wide open. Just a note that we will reserve time today for audience questions. So if you do have any questions as we're going through the session, please ask them in the comments below. Allie and I are joined today by Dr. Ladabaum and Anita, Cory. Dr. Ladabaum serves as director of the Gastrointestinal Cancer Prevention Program at Stanford University School of Medicine, and he heads the Clinical Service Division of the Gastroenterology and Hepatology. Anita Cory is a colorectal cancer survivor who was diagnosed at age 45. Doctors kept telling her she was too young for colorectal cancer, but the science says otherwise, and Anita persisted until she got the support she needed. Thank you both for being with us today. Anita, I'd like to start with you. Your story is quite frankly one of the reasons why we're here today. Can you tell us a bit about your diagnosis and the challenges that you faced in getting screened for colorectal cancer?
Sure. So I had been experiencing some symptoms, but not necessarily the classic symptoms of colon cancer. But just definitely felt off, felt tired, almost like a bloated feeling. And I had been going to the doctor for on and off over about a 2-year period of time, looking for answers. I was told that it could potentially be menopause. I was told I need to just take more probiotics. I need to get more exercise, more sleep. But something still felt off to me. So I actually went to a nurse practitioner within our doctor's office, and she was able to take a little more time with me and looked back at my family history. And my dad actually had colon cancer as well. He was a little older, but still in his 40s when he was diagnosed. So she sent me immediately for a colonoscopy, and sure enough, I had about a 2-inch tumor in my cecum that was found in during that colonoscopy. So I went for surgery and then went for my treatments as well, my chemotherapy treatments. Again, as you mentioned, I was told that I was too young. The chances of me having colon cancer were very slim. But then, of course, they found it. And then when I was going through treatment, I was again told, you're otherwise healthy. Treatment will be pretty easy for you. And again, that was not the case. So I had trouble with my port, experienced blood clots, and had to have my port removed. I was then put on pills, the Xylota pills, after having a reaction to oxaliplatin. So definitely it's been a little bit of a journey and a challenge for me over the last year or so.
Thank you, Anita. I cannot imagine how frustrating that must be. And I think it just goes to show, like you mentioned, 2 years going through that and the persistence required and the personal advocacy needed just to get the screening that you needed. Dr. Ladabaum, to turn to you for a moment, following up on what Anita said, how could these new colorectal cancer screening guidelines potentially make a difference for patients in our work towards preventing this disease?
Thanks, Trudy. The first thing I want to say is to Anita, boy, you've been through a lot. I sympathize. I hope you're doing great. You look great and sound great on the stream. So that's excellent. So a couple of things come to mind. I think it's important for people listening to try to distinguish the potential group in the population they might be in. I would say if the medical system had been absolutely perfect, then it would have known that Anita's dad had colon cancer young. And so that's one group of patients in whom screening is actually even earlier than the age 45 that we're talking about in the Preventive Services Task Force. So for patients who know that they have a family history, or you may want to dig around a little bit, if you do, the current guidelines would say that you should consider screening starting as early as 40 or 10 years younger than when, say, your parent had a colorectal cancer. So that's group one. Different group. Suppose that somebody like Anita had never had a parent with colorectal cancer, but they think that something's different in their body. There's something wrong. There's a new type of abdominal pain that they haven't had before. There's a new change in bowel movement. You say, something's off. Sometimes maybe I've been a little constipated when I was young, but this is different. Or if they have rectal bleeding, that's definitely something different. Or this fatigue that Anita was talking about that may be from a low blood count. Now, what strikes me in Anita's story and many others is the doctors would say things like, you're too young for whatever. There are no absolutes. It's all a matter of probabilities, right? You could say, well, it's unlikely overall just based on age, but then you have to factor in and you say, but with your symptoms, maybe we should think about this. So if you really think there's something different, then that warrants investigation. You should advocate for yourself the way that Anita did. So we have the family history group number 1, 2, people with symptoms. Group 3 is really the main group we're talking about in the general population with respect to the current guidelines. And that basically says if you've reached 45, you don't have family history of colorectal cancer, you don't have symptoms, you should consider screening now. And the reason to do that in persons like that who don't feel like anything's wrong is because there could be the beginnings of a cancer or a pre-cancer that we could find early, and then people do much better when we do. It used to be that the chance of having that happen really began to go up around 50 and older, and that's why those guidelines used to say start 50 and older. But things have shifted for reasons that we don't totally understand into the 40s. And so the simplest way to think about it is that what used to be happening starting in the 50s in the population seems to be happening in the mid 40s. It's taken a few years for the U.S. Preventive Services Task Force to come along in the same way that the American Cancer Society did a couple of years ago. But now there's alignment in saying start in the mid 40s. So to summarize, family history even earlier. 2, symptoms, advocate for yourself. 3, even if you don't feel anything, at 45, you're now eligible.
Thanks, Dr. Ladabaum. That's extremely helpful information because it's a great point that there are different risk levels there. We know that 94% of new colorectal cancer cases do occur in adults 45 plus. So this really is going to impact, hopefully, a lot of those folks who would be identified. Now, to look at the flip side of the coin, Dr. Ladabaum, we know that the National Colorectal Cancer Roundtable's communication guidance recommends a strong recommendation from a healthcare provider that that's the surest way to increase the likelihood of someone being screened. How do you think these guidelines are being received by the medical community, especially primary care physicians who are most likely to make the first recommendation on when a patient should be screened?
Yeah, I think there's been an evolution, and I think the community will come along with enthusiasm. I mentioned before that the American Cancer Society first came out with its guidelines a couple of years ago. The American College of Gastroenterology did recently. What many groups wait for is the U.S. Preventive Services Task Force. So that's kind of like the capstone of all the guidelines. So I think with that, there will be more and more enthusiasm. It sometimes does take a while, and I know that you're going to address this in subsequent questions. So we may be in a period now where people listening to this broadcast, for instance, or other people who read about it, patients on the patient side, they may be a little bit ahead of the curve compared to their general doctor. So we all need to be in on education of the community at large. Few years from now, I think it'll be standard of care. Maybe it'll be months, I don't know. But in this period, I think there is room for advocacy in educating everybody. If I step back for a second, there was a lot of discussion after the American Cancer Society came out with its recommendation saying, should we really be focusing on that, lowering the age to younger people? Or do we redouble our efforts in screening older people who haven't yet come in? And there was a lot of back and forth. I always thought that the US has the resources to try to tackle both. And I think the acceptance is moving towards that, basically saying, okay, we can address the younger group while still trying as much as we can to address the older group. The last thing I'll say is most screening in the US right now happens through a doctor-patient interaction, what researchers call opportunistic screening, basically meaning the patient seeks the opportunity to do it, the doctor takes the opportunity, you're here with a cold, by the way, have you ever been screened? Or you're here for your preventive care, have you ever been screened? That's different from the way that some other countries approach it, which is a systematic population-based program where they reach out to patients once they reach a certain age. That happens in some US systems, but not many. So in the US system, this opportunistic screening really relies on the doctor and the patient. And I think now is this transition period where patients need to advocate until the entire medical community comes on board.
Thank you so much for that. Anita, given your experience, what do you hope the new screening guideline means for younger people moving forward? And how could it then differ from your experience?
Yeah, I think it's so important that we lower the age. And I think of my own kids who I've now been told need to be screened at 35 when they hit that age. So even 10 years younger, which I think again is so important. And I feel very lucky that I did advocate for myself, and that I did finally find someone that would take the time to look at my family history. And I also encourage people to get to know their family history as well and really dig into that and understand if there is something that they need to be aware of, because that does help when you try to advocate for yourself. So I think it's just so important, and I'm glad that there's more attention put on colon cancer. I feel like you hear about it so much, within the last year or so on the news, and so I think it's just really important.
Thanks, Anita.
Trudy, can I just make one point here? So this is I say this with caution, because this is not a place for me to be giving medical advice. And Anita, you shouldn't answer this, and you need to keep this completely private. But I do want to talk about one other subgroup. We talked about the subgroup of people who have a family history. Within that group, there are people who may have particularly high risk because of genetic causes. And so, Anita, if somebody your age came to me and said, I had colon cancer in my mid-40s, my dad had cancer in his 40s, I would say, here we need to go the extra step and think not only there's family history, so your kids need to come in their 30s. This is a situation when one needs to think about a genetic test that might identify your family at particularly high risk. I don't think we should discuss this on the air. I'm just saying for the people to hear about, and it's something that I would think about in the context of family history. There's more routine family history, and then there's family history that really raises the question of whether there's particularly high risk because of genetic reasons. So I think we need to say that in this broadcast so people are aware of that as well.
Yes, and that's definitely something I've been made aware of. I haven't gone through the process yet of genetic testing, but it's definitely something that I plan to do.
Great. Thank you for that addition, Dr. Ladabaum. I do want to bring in Allie here, and we are seeing some of the questions that are coming in from our audience as well. So I'm hoping we'll get to some of them in just a moment. And maybe, Allie, you can cover off on one of them even and where we're going next. But the new screening guidelines are a major step forward, but they don't yet really have teeth. Insurance companies are mandated to cover preventive screenings based on the U.S. Preventive Services recommendations, but the timeline for that is a bit unclear. In other words, if a 45-year-old goes to their doctor today, there's a good chance their insurance would not yet cover a preventative colorectal cancer screening. That's a major issue that the Alliance and others are working to resolve sooner rather than later. But Allie has some ways our attendees can help now. Allie, how can people get involved to ensure preventive screenings are covered?
Great question. Allies, we are asking you to make a friendly call to your insurance provider. Do it today. Find out if they cover screening for CRC at 45. We have a script that makes it really easy. All you have to do is sign up to help, and you'll get that script in your email. There's a link in the comments, or there will be very soon. And, a lot of us know in a very personal way, like Anita, Christine, Kim, Kelly, I see you in the comments. A lot of us, this issue is very personal, and we know what a slow adoption will cost others. And let's put that into helping. And if you want to be an advocate, use that script, sign up to be a volunteer. There is a lot to do. We can really make a difference. We can do it right now, and we can't wait.
Thanks, Allie. We're going to turn to the audience for questions in just a moment. Right now, though, Dr. Ladabaum, as insurance companies figure out their timelines to implement the age 45 guideline, is there a way that younger patients can advocate for themselves and get the screenings that they do need?
I think it starts with the advocacy and saying, I'm 45, I understand I'm eligible, can I get screened? If there is a barrier at the level of the insurance at present, then we can try to request as the treating clinicians that this patient be screened based on current guidelines. It does take a little effort. These pre-authorization administrative tasks are kind of annoying sometimes, but until they come on board, one could do that. Will the insurance companies then say, okay, yeah, you're right, let's do it in this case? I don't know. But I think we have to start with that push until it just becomes policy across the board.
And it really sounds like pushing from both sides, both the patient advocacy side and the medical community saying these are the guidelines, right? Thank
Trudy,
you so much.
can I add something there? Just a quick note on that. That's such a great point. And I did just want to remind the folks viewing at home, if you do have trouble with insurance, the helpline that is free and that the Alliance offers, we can put the number in the chat. We actually have a certified patient navigator with a specialty in insurance. So I just wanted to give that reminder if you're struggling. We do have someone who can help try and navigate you through those challenges.
Thanks, Allie. As Dr. Ladabaum noted before, we do want to say that anyone who is experiencing symptoms or has a high risk of colorectal cancer due to family history of the disease or a hereditary condition associated with it should not wait till age 45. Definitely talk to your doctor now, even today, given your understanding of the conversation today. I do want to call attention to the chat below. We have been sharing resources and will continue to do so that you can use to learn more about the new colorectal cancer screening guidelines and actions you can take to influence insurance companies to apply them. Now we'll take some questions from you, our audience. And the first one, Dr. Ladabaum, is for you. One of the questions is around ctDNA testing, which detects evidence of tumors in the blood. Lada has asked if there is a negative result one time, can it be positive at a later time?
Yes, a complicated question. So I'll just first give a disclaimer that whatever I say now should be overridden by your treating doctors because they know your situation. But for everyone who's listening, there are currently applications for testing for evidence of cancer cells in the blood in patients who have been diagnosed with cancer and treated. And so it's a monitoring to see, are you free of cancer now, or do we need to think about additional treatment? That is one potential area of monitoring. And unfortunately, yes, if the test is negative at one point, it can be positive later. So this is where I can't say anything very specific. Patients need to follow the care, usually of their cancer treatment doctors or surgeons, in terms of how to monitor and how often it should be done and so on. This is now really under development. A completely different potential application for these signals in blood would be for screening, which is what we're talking about today. So the main screening methods today would be to look inside the body with a scope, with a colonoscopy, or to look for signals of blood or other markers in poop. Those are the main ways to test. There are some radiological or X-ray tests like CT colonography. Those are the main screening methods we're talking about today. An emerging one is a camera that you swallow. But there hasn't really been a great blood test yet. There are a lot of blood tests under development that one day may be the way to go, where you're just going to get your blood drawn. So I do want to distinguish between monitoring for whether there's still residual cancer in patients versus screening. And the question I think that was asked here is really more about monitoring in terms of cancer care. And there it needs to be done with caution, with careful discussion with your cancer treatment team.
Thanks for that. Ali, just to nuance a little bit some of what we discussed around insurance questions, we have a question from Aaron about how are insurance companies reacting? So can you tell a little bit about the people who have already called and like what we're hearing?
Yeah, sure. And I'll first say that my information is anecdotal and also totally reliant on incredible advocates responding to my friendly email asking how the call went. So know that I will ask you if you sign up. I want to know. I want to be supportive. We want to be supportive, and we want to learn from what you do as an advocate. So by the way, put a chat in if you plan to call. I would just love to know how many of you would like to help as an advocate on this issue. So far, most folks that our advocates have spoken with have not been aware of the policy change. And there could be a lot of reasons for that. But I think overall, it's important to remember that I think most people that get into the healthcare space in any way, they want to help people. They want to save lives. So remember that when you call, your orientation is as a member that is concerned about an issue that's important to you, and it is helpful and friendly, and we are all working on this together. We're just making sure that things happen in a timely way. They can count on us for that as a patient advocacy organization. So our Nation of Allies is a really important part of that, and we need to get this done. And I can't wait to start hearing they're on it. That's what I'm waiting for, and I know we will. So that's the news. It's not that good, but that's why we're doing this.
Thanks, Ali. And I want to echo, go back to one comment with Yuri's response just a moment ago about the different testing types, the screening testing types, and note that the guidelines did have a couple of other key points within this. And one of the points that I think many people who responded to the draft recommendations was really around the point of if you get any type of screening test other than colonoscopy and there is some kind of positive or abnormal result out of that, the guidelines do specify now that any person who completes the screening other than colonoscopy and receives that abnormal test result, really then follow-up is needed, and most often that will be colonoscopy. In our opinion, that follow-up colonoscopy is critical. Screening is not completed until that point, and that was new language within these guidelines as well. So I think it's an important punctuation point that screening has to be completed all the way through a negative result or the finding and removing of polyps, adenomas, or the identification of cancer. And the idea there that we're pushing ourselves down where we have fewer cases because we have people being screened earlier, where we're identifying cases through early detection at earlier stages where there are higher survival rates. So we couldn't do this without you, and we appreciate all of you for watching today. That is all the time we have for today. We truly appreciate you all being here with us. I want to thank Anita, especially for sharing her story, and Dr. Ladabaum for giving us some context around the guidelines and the medical community. Thank you so much for being here. If you want more information on screening in particular, you can visit getscreened.org, or get your personalized colorectal cancer screening recommendation by taking our screening quiz at quiz.getscreen.org. Thank you again, and we look forward to hearing from you soon.
Thank you.
Thank you.